Case study presentation by Gail Bryant. At the end of this session, you will be able to gain an understanding of the prevalence of psychotic illnesses, describe the key features of a brief psychotic behavior, understand how to differentiate between psychotic illnesses, select psychopharmacology treatment for brief psychotic illnesses, and also apply general principles on how to approach a patient with psychosis. Let's review the case study. Laura Gonzalez, a 51-year-old divorced freelance journalist, brought herself to the emergency room requesting dermatological evaluation for flea infestation. When no corroborating evidence was found on her skin examination, the patient insisted that she was unsafe at home. She was admitted to an inpatient psychiatric service with unspecified psychotic disorder. Mental status exam. Ms. Gonzalez was calm and easily engaged. Normal eye contact was maintained. She offered up a small plastic bag containing fleas and larvae that she collected in the hospital while awaiting evaluation. Inspection of the bag revealed lint and plaster. Her speech had an urgent quality to it, and she was described her mood as sad right now. She was tearful intermittently, but otherwise smiling reactively. Her thoughts were overly inclusive and intensely focused on fleas. She expressed belief that each time a hair fell out of her head, it would morph into larvae. When crying, she believed an egg came out of her tear duct. She was not suicidal or homicidal. She expressed an unshakable belief that lint was larvae and that she was infested. She denied hallucinations. Cognition was intact. Her insight was impaired, but her judgment was deemed reasonably appropriate. Her stressors. Her worries about infestation began in the setting of her sister's diagnosis with invasive cancer, onset of her own menopause, financial strain that was likely forcing her to move from the United States back to Argentina, her country of origin, a recent breakup with her boyfriend, obsessive person who had always had contamination phobias, which historically worsened during the times of anxiety. Questions. Are psychotic symptoms related to stressors? Does the patient have a medical condition that predisposes her to psychosis? And is the patient using drugs or alcohol? Other information gathered. Results of Laura's neurological examination were normal. Laura's head computed tomography scan was normal. Laura's laboratory tests were negative. Toxicology reports were also negative. History. No one in the family had a history of psychiatric illness. Ms. Gonzalez had depression once in the past and was briefly treated with an antidepressant. She had no relevant medical problems. Other diagnoses that can appear to be a psychotic illness. Delirium. Patients often have paranoia, visual hallucinations. Paranoid personality disorder and schizotypal personality disorder can dance very near to the edge of psychosis. Obsessive compulsive disorder, at times, obsessions can be difficult to discern from psychosis. How can we identify the diagnosis? Establishing diagnosis requires three essential elements of the history and physical in an individual. The presence of at least one positive psychotic symptom such as delusions, hallucinations, disorganized speech, or disorganized or catatonic behavior. Establishing that symptoms have not been present for less than 1 day or more than 1 month. Investigating if the disturbance in behavior is otherwise explainable by another mood disorder, medical condition, or substance or medication use. Differential diagnosis for psychotic disorders: substance-induced psychotic disorder, delusional disorder, psychotic disorder due to general medical condition, psychotic disorder NOS. Given the information on Laura Gonzalez, what is her diagnosis? Brief psychotic disorder with marked stressors. A brief psychotic disorder is an uncommon psychiatric condition characterized by sudden and temporary periods of psychotic behavior. These include delusions, hallucinations, and confusion. Symptoms can endure for only 1 day or for as long as 1 month, but may be severe enough to put the person at increased risk of violent behavior or suicide. A majority of cases present for the first time when an individual is in their 20s or 30s, although onset can occur at any age. Brief psychotic disorder is differentiated from other disorders in which psychosis occurs by its limited duration and is not triggered by drugs or alcohol abuse. In most cases, a brief psychotic disorder does not indicate the presence of a chronic mental health condition. Presence of one or more of the following: delusions, hallucinations, disorganized speech, disorganized or catatonic behavior. Duration of episode is less than 1 month with eventual return to pre-morbid level of functioning. What are hallucinations? Hallucinations are defined as false sensory perceptions not associated with real external stimuli. Delusions are defined as a false belief based on incorrect inference about external reality that is firmly held despite what most everyone else believes and despite what constitutes incontrovertible and obvious proof of evidence to the contrary. Establishing rapport with a psychotic patient. Acknowledge you believe they are experiencing what they're reporting. Try not to collaborate with the patient. Try to establish rapport before confronting psychotic beliefs. Don't be overly friendly or it can feed into the paranoia. Laura was discharged on a low-dose antipsychotic medication and seen weekly for supportive psychotherapy. Medication adherence is prevalent in FEP and associated with a variety of factors. This study supports the use of cultural appropriate interventions in addressing barriers to adherence. Treatment for acutely psychotic patients may vary. When the patient has an unknown cause of psychosis with no known history versus known or suspected and psychotic illness, treatment may vary. See below. Treatment. Mindfulness training has been shown to have moderate efficacy for patients with psychotic disorders in a recent meta-analysis. Physical exercise, which can reduce stress, has likewise been shown to alleviate psychotic symptoms in another recent meta-analysis. Stress sensitivity can be directly addressed through psychotherapeutic approaches such as cognitive behavior therapy, which has been shown efficacious in treating psychotic symptoms. Stress alleviation is likewise a key component of attempts to prevent or delay onset of schizophrenia in help-seeking youth at clinical high risk, among whom cognitive therapy and supportive therapy appear to be beneficial. Being employed was associated with overall better relationships and environment among patients with FEP, and higher education achievement was associated with improvement of physical health, social relationship, and environment. Hence, educational achievement and employment could be considered for future optimization of early psychosis intervention programs. Treatment goals: decreasing positive, negative symptoms of psychosis, reducing secondary symptoms such as anxiety, minimizing the likelihood that other disorders develop such as substance use or depression, enhancing quality of life, minimizing disruption to the person's development in such areas as school, work, and social pursuits, maintaining or increasing cognitive abilities such as concentration and memory, minimizing side effects of medication. Outlook or prognosis. Laura's preoccupation improved within days and resolved entirely within 2 weeks. She developed enough insight to refer her to the belief that fleas were in her skin as a crazy thought. She attributed her break from reality to multiple stressors and was able to articulate that she relied on her delusion as a way to distract herself from real problems. Her family corroborated her quick return to baseline. Most people with this disorder have a good outcome. Repeat episodes may occur in response to stress. Conclusion. As with most other psychiatric pathologies, the diagnosis, treatment, and management of brief psychotic disorder requires the coordinated efforts of a strong multidisciplinary team that includes the primary care provider, mental health nurse, psychologist, and psychiatrist. It is paramount to develop and follow a patient-centered approach with particular focus on psychotherapy and pharmacotherapy, given how disruptive such a disease process can be to the patient and his or her family. Working on the biopsychosocial aspect of well-being will ensure that the patient is well supported all around and help curtail the overall negative impact of this disorder on the life and functioning of the individual. References.